In urothelial cancer, in the last 20 or 30 years, there's not been a lot of new treatment development, and unfortunately mortality has been pretty constant over the past 30 years. In about 2016 to 2017, we've had 5 new checkpoint inhibitors which were approved by the FDA and were shown to be of interest and effective in this patient population. So Atezolizumab is one of those checkpoint inhibitors. And so what we wanted to do is we're trying to find out which patients would benefit most from treatment, which patients should get which treatment, and that still isn't undecided because people aren't sure of what's going on there yet. And so as a result, we wanted to look at one particular drug, which is Atezolizumab, and evaluate which patients might benefit the most from it. And that's where our 6-factor model was developed. So what we did is we took all the clinical prognostic factors, or all the clinical factors that we could get information on, and used some statistical techniques to try to identify which factors would be the most prognostic and which ones would indicate which patients benefit the most from treatment. And so that's how the 6-factor model was developed. These patients are patients who have received prior platinum, and we found that these 6 factors, neutrophils lymphocyte ratio, anemia, platelet count, ECOG performance status, the presence of liver metastases, I forget one more. But these 6 factors were prognostic, were best able to risk stratify patients into good, medium, and high-risk patients. And the model was developed in one particular clinical trial called the IMvigor study, and then was validated in a second clinical trial, a PCD study. They were both using Atezolizumab in the post-platinum setting. And the results that we saw were similar in both the initial data set as well as the second data set that we evaluated, what we call the validation data set. So this particular model appears to be of interest, and appears to be of interest to develop or to risk stratify patients into high risk, moderate, and low risk patients. In terms of clinical use, I don't know that it's ready for clinical use just yet, because it's been just on these 2 particular data sets. The second validation data set was only a population of 95 patients. I think there's other factors that we may want to look at as well, but it should give some idea to clinicians who are trying to decide which particular treatment we should give to patients, how often we may want to follow up with these particular patients, and how do we decide between the different therapies that are out there right now for these patients.